All right. Let's see if I can get this working. I know this is weird, this picture, but I want you to look at this man. He is, in this picture, 61 years old. It was April of 2004, and he died in July of 2004. In December of 2000, this is my father, and this is my daughter. In December of 2000, he showed up at a rural hospital. His symptoms were double vision, slurred speech, leaning to the left, sweating profusely, and reeking of a sweet smell that was a lot like alcohol. My mother, who had just graduated nursing school, went back to school a few years before, was with him. She was going through, she had just had a mastectomy, going through cancer treatment. And the ER doc in the community, the ER doc overworked, didn't have the right resources, everything, looked straight at my mother and said, he's pulling him one, he's drunk, he needs to sleep it off. My mother tried to advocate for him, did not win. After hours of sitting in the ER, she finally checked him out, AMA, and drove him an hour and a half to the first tertiary she could get him to. Immediately, the neurologist looked at him, read the scans, and he had what's called a Wellington stroke. It's a stroke in the brainstem. It's probably one of the worst strokes you can probably have. You have about a 50-50 chance of survival. If you do survive, you lose your subconscious, unconscious motions such as swallowing and speech and so forth. He went through long term for those couple of years that he had after it of trying to learn how to swallow again. And he forcibly made himself swallow again in order to not have a feeding tube. He finally learned how to walk very slowly with a cane, but you can tell he has a 20% degree because he walked like an angle because he never could get straight again. I tell you this story because those years, and it chokes me up every day, changed my life. I was not in healthcare at the time. Never wanted to be in healthcare. I'm a nerd. I'm a tech person at the end of the day. But that was my community that this happened to my dad. So, let's see. Fast forward, things changed. I lost my dad in July, lost my mother about a year before I lost my dad. Fate had it that it changed my life, and what I really wanted to do is not make as much money, but make a difference in the world. So navigated things, ended up in healthcare. Fast forward again, I end up over telemedicine. My name's Penni, Kyte. My title is Digital Care Strategy Officer for Ballad, but I want to explain to you what I do for a living because it'll make sense. I've got telemedicine, but I've also got the Patient Transfer Center, the Regional Communication Center, which is EMS flight and EMS and flight. And then I've got centralized bed placement and emergency communications when we have emergencies. That's all important because that's how I look at things. When things come through, we've got to take care of the patient. So when I ended up with responsibility for telemedicine, which was only 3 years ago, the first thing I realized is, guess what? That community I just told you about in Southwest Virginia, of all the hospitals they have in Southwest Virginia, only two of them had teleneurology services. The other 6 still did not. 2 of those hospitals were 2 of the highest hospitals for emergent neurology issues, and the patients were being transferred out. And again, I'd said earlier, it took an hour and a half for my mother to drive my dad to the closest tertiary. So we set out on an initiative, a venture. The first thing I wanted to do was try to get telemedicine, teleneurology, emergent teleneurology in every single ER that I could touch. So we worked through it. And if anybody knows about working in a health system, you've got to somehow make that ROI meet with everything else. And we did it. We did it. Finally got sign off, finally got approval. Then we worked on the plan, because even if, and that's why I've got the easy button up here, even the best laid plans, if you don't figure out how to get that frontline staff bought into it, they'll roll that cart right over to the side and it'll never be used. So we spent a lot of time going to these hospitals, understanding the process. The process is never the same at every single hospital. It always changes. And we documented it. We documented current state. We documented how they did everything. Then we came back and we worked an RFP process, and we worked trying to figure out the best plan. And rather than let vendors come in and tell us how they can provide telemedicine, we told the vendors how it was going to be easier for our front line to do it. So things that we did. First, we made sure that we took the nurse out of the process. If there was an emergent teleneurology, that ER doc needs to talk to that neurologist. I don't know how many of y'all know this, but a lot of times, at least where I work, the ER doc wants that nurse involved with everything. Well, there's not a problem with that, other than that nurse is all she's doing is connecting the teleneurology service for them, and that doc needs to be the one to cut down some of that delay. So we ended up rolling out a unique telephone number for each one of our hospitals. That ER doc has that number. That ER doc can pick up the phone, call, gets an emergent, gets a teleneurologist immediately on the phone. Just to tell you how much better it is, when we started on the left, this will show transfers saved. So we rolled out first phase, emergent teleneurology, and we documented the number of transfers where that we kept, the number of patients that we kept at the local hospital. And you can see here, they ended up being about 2,500 patients last year that we kept at the hospital, at the local hospital. And what does that mean? We've talked about it all day long. Southwest Virginia, any kind of rural area, first of all, they want to be close to home. My dad, he'd only been to the doctor twice in his life. The first time was a checkup that my mom fussed at him over when he was 40, and the second time was when he had a stroke. So, and a lot of rural health, a lot of people in rural health are like that, in rural communities are like that. So we have to keep them close to home. The other thing is, and at least I know in Southwest Virginia, because I'm from there, is when one goes to the hospital, they all come to the hospital. My uncle was in the hospital 2 weekends ago. There was a whole family crew there with him, including me, checking on him. So wherever the family member goes that's sick, 2 or 3 family members go with him. And when you do that to a community that the average salary is about $34,000 to $38,000 a year, you put a huge financial impact on them, not only in driving, but in the EMS costs and everything else. So thinking about all of those factors is why we really wanted to focus on, are we making a positive impact, not only to transfer saved and making sure we keep the patient at the most appropriate facility, but also, are we making a positive impact for the patient? Because I can tell you stories that Russell County, Virginia, we had to send a peds patient one time to Niswonger. The ER took up money because the family didn't have enough money to get to Niswonger. That's not taking care of patients. You got to take care of the social side and the medical side. So we saved the transfers, but when you look at the transfers, there's still some that had inpatient volume. So even though we got the thrombolytics to them, there were still some that needed inpatient coverage, and we would have to transfer them. So phase 2, what we did was worked on inpatient rounding, teleneurology inpatient rounding. So at the hospitals that had inpatient beds, we worked on a process that included a navigator and the nurse working on a schedule to roll that cart, for lack of better words, to every single neurology patient so that they could do a consult and keep that patient at that community hospital. Again, it's another set, I think it was another 1,500 patients we saved from having to be transferred, and they could stay locally. The other thing we've done is the time to specialist. Remember I said we only had 2 hospitals that had teleneurology services out of about 8 in the rural area in Southwest Virginia. The average time for all of them, because the ones that had teleneurology could get teleneurology within 30 minutes. The ones that did not had to call the transfer center, and we had to connect them with the neurologist to talk, which took longer. So the average time was about 45 minutes to get to a neurologist if you talked about those 2 separate processes. Once we did a system-wide one-call teleneurology, the time to neurologists went to 26 seconds. The time to getting thrombolytics is under 60 minutes for those hospitals I'm talking about. And all it took was listening to the front line, trying to get the cleanest process, and trying to make sure that we take all the extra steps out of the way and not make technology so difficult for them. So we did another step. One of the other delays after we got started, and we tackled the ER, we tackled the inpatient, radiology delays, reading the image, reading the image. We were waiting and waiting for somebody to read the CT. So then we started thinking, how could we cut that time down? Because that could affect time to thrombolytic. So we began to work on how to utilize AI. So we invested in AI in order to give recommendations and to find the issues with the stroke sooner than later. If you look, we started at the first 5 hospitals first. We had 506 scans and only 32 alerts. With all of the hospitals, we have 728 scans and 37 alerts. The AI technology has sped it up even more. Lastly, these are the areas that now we have a system teleneurology in the ERs. Now phase 4 is outpatient. We've taken care of the patients on the inpatients. We've gotten them through the ER. We've gotten into the inpatient. We've gotten the scans read faster. Now we're sending them home, and that neurologist is still an hour and a half away. So that's going to be the next phase to try to work through and figure out how we continue to provide that teleneurology services. And that's it.
Thank you.